welcome everybody. We've got a mixed audience here today. Would you mind closing that door? Thank you. So the aim of this will be an introduction to weight loss surgery. So what I'm going to do through this process is I'm going to cover kind of three main areas. The first one is how we select patients for weight loss surgery. The second area we're going to talk about is just the basics of technical aspects of more common procedures. And I will concentrate mainly on two procedures. One is gastric bypass, and the other one is a sleeve gastrectomy, which are now routinely done laparoscopically. And then finally I'll finish with just an overview of how we approach complications after bariatric weight loss surgery. And hopefully at the end, if you have any questions, or you're welcome to stop me at any point if you have any questions. Ask. So some definitions first of all. And these are relevant because if you don't know them, then you might not fully understand this talk. So the first one is the body mass index. So some of you guys, some of you are students, so you're all familiar with body mass index through your lectures. So a body mass index is essentially your weight in kilograms divided by your height squared, but in meters. Okay. So you can see how you can have a relatively higher body mass index in an individual with a particular weight who's shorter than another person with the same weight who is taller. All right. So that's the first one. The next one is this notion of obesity. So generally speaking, anything up to about a BMI of 25, we would say is normal weight. So between 25 and 30, we have patients who are overweight, and then 30 onwards, they are essentially obese, which are then classified into subgroups. And the last one is the percentage excess weight loss, and that's very relevant in most literature that you read in surgical journals. Now I'm going to describe what that means. Percentage excess weight loss. Let's just imagine that I weigh, these are imaginary, arbitrary figures, okay? Let's imagine I weigh 100 kilograms right now, okay? But my ideal weight is 50 kilograms, okay? And by that I mean if my BMI is 25. So I weigh 100 kilograms, but I should be 50 kilograms. So how much excess weight do I have? 50 kilograms, okay? Now just imagine that now I drop my weight, say through dieting, from 100 to 75 kilograms. So in other words, I've lost 25 kilograms in weight. Remember, I was 50 kilograms, I had excess weight, of which I've lost 25 kilograms of it. So what percentage? I've lost 50% of my excess weight in weight. Yeah? So that's the percentage excess weight loss. In surgical terms, after surgery, if you've achieved 50% or more of weight loss, essentially that's acceptable outcome. Because beyond that, you would have taken risks through surgery which would be worthwhile for the benefits. Whereas if you were to diet and you lost any weight, essentially a certain 5%, is quite acceptable. Because the risk that you've taken through dieting is minimal compared to the gain of the 5% in your health. So how do I choose a patient for surgery. Now I'm going to point this line, these two lines here, okay? And in particular, this one, this last line, I'm going to mention it first. Now, many patients meeting the surgical criteria never consider surgery. So, if you consider in many Western populations, 50–60% of the population are now overweight or obese. Okay? And of that large majority of patients, there are sizable patients that, on paper at least, meet the criteria for bariatric surgery. But not everybody is willing to have surgery. And perhaps, even if in theory they would meet all the other criteria. So the willingness is obviously quite important. But we also want to find patients who are compliant with surgery. And the way we're going to find if a patient is compliant is not through words, but through patients' records. For example, in our local protocol for bariatric surgery, we would select patients who have been able to comply with advice given by the dietitians preoperatively and have managed to lose weight. We aim for 5 to 10% of their total body weight loss, which is quite a achievable target. It's an indirect indicator that such patient is compliant with advice. And also, for example, a patient who comes through the dietetic arm who's been a good attender, has been a very good attending records, and is being compliant with advice through weight loss. Generally speaking, those patients are probably better for selection. There are counter-arguments against this, but remember, we have a finite resource and we have many millions of patients that we could potentially operate on. So you would want to choose your intervention surgery for the patients that would give you the best results. And one of the ways is you would want to pick compliant patients. What are the criteria of the BMI? Now, anybody who is above the BMI of 40, essentially, will automatically on paper fall into the surgical category. Now, if you're a BMI of 35 to 40, and you have a comorbidity, which is usually reversible with weight loss, such as, for example, diabetes, type 2 diabetes in particular, then they also fall into that category. So if you are a BMI of 35 to 40 with comorbidities, or if you've got a BMI of greater than 40, those are the patients based on the BMI that fall into the surgical category for us, based on the guidelines. But they also need to be physically fit. Now, a patient with a very high BMI, by definition, is not going to be physically fit. So you need to define what that fitness is. And this is where essentially you want a patient who is fit for surgery. And this is why you want a close contact and consultation with your anesthetic colleagues. But we all, through time, have learned to select the type of patients that we feel are fit and essentially exclude patients that are clearly unfit. A patient with major cardiorespiratory disease, severe heart failure, end-stage lung disease. These are the kind of patients that essentially are not fit for general anesthetic or for major surgery, so they will be excluded naturally. The problem arises in the borderline cases, and in those situations, one of the important things to do is that perhaps the patient might not necessarily be fit at that moment of time, but the question is, can you make that patient fitter? And the way that you would make the patient fitter is weight loss. If they carry less weight, they become more mobile, and they can do more exercise. That's not possible all the time. If their diabetes is very poorly controlled, perhaps that should be controlled better. Sometimes it's not possible. If they've got any reversible conditions physically that can be optimized, well, that's what you need to concentrate on. All our patients get psychologically assessed once they've reached a point where we would want to list them for surgery. There are very few patients that we will exclude based on psychological assessment. In our experience, in my experience, most patients who we sent for clinical psychological assessment do pass the psychological assessment, but they need to be assessed mainly because they might need a little bit of workup psychologically prior to surgery, but critically for post-operative support. So the patient's relationship with food is a big consideration. If you have done a procedure that essentially will deny this patient from eating, and food was something that the patient used for stress relief, that can create a lot of problems post-operatively. That's one example. So you need to be prepared, and a lot of patients do need post-operative support through psychological input, and they do get followed up. So it's mostly post-operative support rather than pre-operative selection. There are some group of patients that you might want to be more careful in offering surgery, and particularly the ones who have got major ongoing psychiatric illness, which are under current active treatment. The very recent suicide attempt, major personality disorders, these are the kind of patients that we definitely want to have a close discussion, most likely in a multidisciplinary sort of situation with your colleague in clinical psychology. A lot of these patients will need a lot of workup prior to surgery. So many patients requesting surgery don't meet the criteria, but many patients meeting the criteria never consider surgery. So that's the dilemma we always have. So Roux-en-Y gastric bypass is, for us in our unit, tends to be the gold standard. The reason for that is because it gives usually the most predictable outcome, as opposed to some other procedures, for example, a sleeve gastrectomy or a gastric band. We currently don't do gastric bands in our unit, but essentially you can kind of divide bariatric weight loss surgery into subgroups. There are groups of procedures where are purely restrictive. And by that I mean you're restricting the stomach size so that the patient is unable to overeat. And there are other procedures which perhaps have got a malabsorptive element to it. So even if the patient eats, it doesn't get absorbed. But also it could be a bit of a mixture of both. They've got not only malabsorption, but also restriction. And gastric bypass is one of them. So you're not only causing restriction, but you also got an element of malabsorption. You're bypassing an element of the GI tract, which is involved in food digestion. This is quite variable, but in my experience, typically 65, 70%, maybe close to 70% excess weight loss is what you would achieve. And this means that the patient very often ends up about maybe 20, 30%, 35%, sometimes even 40% still being overweight compared to BMI 25. And that's very important to when you're consenting the patient in your clinic, to clarify that with the patient. say if a patient is say 200 kilograms overweight, so excess weight of 200 kilograms, well, even if that person loses 70% of that excess weight, so that's 140 kilograms, that still leaves you with 60 kilograms of excess weight. So the patient is still quite heavy, but in a much better position because of such big weight loss. So patients need to be realistic about goals. They need to be par with your goals, so that you need to be in the same wavelength with the patient about the expectations of the outcomes there. So what are the steps of a gastric bypass? So briefly, I'm going to do some drawings for you here. So if you think about, first of all, nowadays, gastric bypass actually predates laparoscopic era. It's used to be open for the same reason for weight loss. But if you can do it through minimal access, then it's far better because it's quicker recovery. So we do them nowadays laparoscopically. So for a laparoscopic procedure, what we will need is we need ports. So belly button, okay, and this is the costal margin, and this is legs down here, okay. Now firstly is you need landmarks. Now one of the first things that you learn in patients who are obese and super obese is that umbilicus is a very poor landmark in heavy patients, and the reason for that is because it could be quite variable depending on the patient's size. I mean, there are patients where the umbilicus could be quite deviated from the midline, so that's not a good landmark when you're deciding where you're going to put your ports. So I would usually use the xiphoid process and the costal angle as the landmark. It usually doesn't matter how obese the abdomen is. Usually, as you go higher, the fat layer becomes thinner. So even in super obese patients, you'll be able to feel where the chest ends and abdomen starts. So one of the things that you would want to consider is how you're going to get into the abdomen, which is a talk in itself, okay? But there are different ways that you can access the abdomen. For those of you who might have worked in some subspecialties where they use needle entry called varus needle, it's becoming perhaps less fashionable, and there are newer techniques. For example, you can have ports where the tip is transparent, where you essentially put your 0-degree scope inside, you make the incision in the skin, and then you're basically inserting this port under direct vision, and you can actually see the layers as you go through. Now, some of you are medical students, so you would have done anatomy at some point, and you will remember the layers of the abdominal wall. And these layers are from the very top, obviously the skin, then you've got the fat, all right? And then after the fat you get what? The anterior rectus sheath, then you get the muscle, then you get the posterior rectus sheath, then you get what comes after posterior rectus sheath?
In the midline.
And let's say here.
Oh, over there.
Yeah.
So you've got the external.
So you've gone through the muscles.
Gone through the muscles.
So now you're beyond the muscle.
In
and
posterior rectus sheath, you've got the preperitoneal fat.
Okay, good.
Okay.
So the preperitoneal fat and then the peritoneum, and then you enter the abdomen. And you can clearly see these layers, particularly if you're not in the midline. And that's the important thing, right? So if you're in the midline, obviously you've got the linea alba, So these layers are not visible. And then right underneath, you might have falciform. So these layers, if you're unlucky enough to make the incision bang in the middle for your port entry with this optical access, often you might run into problems for those reasons. So one of the things, for example, a lot of surgeons, including myself, do is when you enter the abdomen, you go to the palmos point, we go up here, which happens to be a place where the rectus is quite thick. And if you think about the rectus sheath in the midline, it kind of does that, doesn't it? You know? So the more you are towards the center here, the better you can see the layers when you're entering the abdomen. And that's a quite important technical consideration for surgical trainees. So the first point that I would go for is over here, in the palmos point, kind of in the mid-clavicular point. And you just go for a 12 port because the staplers don't go through any 11 port. So you use a 12 port, and you either use a optical access, or if you have access to it, is a VisiPort. People can look up VisiPort. Essentially, it's got a blade, actually a gun, and as you fire it, a blade comes out and it just makes a very small incision and it retracts back. So it's a combination of cutting, especially the sheath, as opposed to the pointiness of the optical access of the conventional port. And it does have certain advantages. In my experience, what it does is it reduces the amount of force that you need to apply to get into the abdomen. As opposed to the pointiness, and it requires a little bit more force to get into the abdomen. So the first port here, and then you need further ports for, so one of the ports that you would put here, roughly in the middle here, and perhaps one hand and one thumb down from the xiphoid is another 12. And through this 12 port, you will put your camera, your 30-degree scope. And you will have changed your 0 to 30 degree by this point. You need another 12 on this side, and your liver retractor up there through a 5 incision, a small incision. I usually use a Nathanson's retractor, which then gets attached to a striker type clamp and lifts the liver up. And you would need another 12 here, and you might put another 5 out here. The distance between these 12s are usually 1 handbreadth. And each abdomen is slightly different, so you can't be too prescriptive. You just need to kind of scrub with more senior members or people that are training you, and you see how they analyze it. And for each surgeon, it's slightly different depending on whether they use hand sew, whether they use stapling, whether, depending on the technique they use, you know, the different techniques for gastric bypass. It can vary a little bit, but essentially you need a combination of liver retractor, 12 ports, 30-degree scope, and ports for your assistant. The legs are usually split, and that gives the advantage of at least somebody to be able to stand between the legs and the surgeon and the assistant and the scrub nurse, either on the right or left, but typically on the surgeon's side. So in my case, for a bypass, I will stand on this side of the patient, on the patient's right. My camera person will stand in the middle of the legs, and my assistant is on this side to hold this 5mm instrument for retraction. And the scrub nurse usually stands on my right-hand side. And that's the orientation. And then, because I'll be looking in that direction, I will have one monitor at my eye level over there, and my assistant will be looking at another one over here in that direction. And that works for me. I know there's variation in this format. So it's important to fix the patient appropriately to the table. So one of the things that you need to kind of visualize for this one is, if you think about a very heavy patient, with a very thick fat layer, what happens is that the first thing important to consider is this, that the body essentially, the skin will remain in contact. Imagine if that's the skin and this hand is the body, okay? And in between, this layer of air is the fat. So what can happen is that as you move the patient, say head up, the skin remains where it is, but the body moves. And so you can see what happens to the body, and what happens then is that it can put a lot of pressure on the skin, and that's where problems arise. So that's the first thing. The second point is that you do not want a heavy patient, or any patient, to fall off the table. And it doesn't have to be the whole body, it could be a limb. And that can cause problems, big problems, with dislocation and nerve injuries and bony injuries. So that's very important. So you need to fix this patient appropriately. So what, for example, in the theatre where I operate, is that both of the arms are out like this, and the patient legs are fixed in two important ways. One is that the patient's essentially heel is being supported with a plate on both sides, but also the knees are kept extended with two straps. So that way, if you do stand the patient up with a head up position, what is happening is that the weight then is transferred down to the leg, and the knee is not bent, so the whole leg and the spinal cord and the spine is acting as one column. So the body is not moving in relation to skin. So you're not in a position of then patient slipping or sliding. So that's a very important consideration. Fixing the patient is very important. I sometimes do this exercise with trainees or students, and if you ever do this at home, so all you have to do is this. If you stand up, don't do it now, but I'll do it for a few seconds just to tell you what you could do. If you stand up and if you extend your right or left arm and supinate, and then bring your neck in the opposite direction and hold in that position for even 2-3 minutes, you will feel a hell of a lot of discomfort along the nerve. And you actually start getting numbness along the nerve. And that's the kind of thing that can happen. That's one example where you've got patients' arms extended, and the patient slips, and you see how you're then suddenly hyperextending the arm, and that's how you can get brachial nerve injuries in heavy patients. So fixing the patient is really important, and it takes time. So the whole team needs to know what they're doing. Once you're inside the app, and incidentally for those of you, I'm not going to show you a video, because all you have to do is, after this one, is to go and watch a video on YouTube. There'll be plenty of examples. So the next thing that you would want to do is, after you look and do the diagnostic laparoscopy, because you don't want to miss things, incidental findings, for example, is you want to make sure, these are the kind of things that I always make sure, is the stomach, because you're going to do a gastric bypass, is the stomach in a good shape? Are there any incidental findings, whatever that is? Okay, I don't want to go into all the possibilities here. Critically, is the small bowel in a good shape? Because you're going to bring the small bowel up to anastomose, and I will draw what you need to do in a minute. So if the small bowel is not in good shape, then you can't use the small bowel. I mean, for example, let's take an example of a patient where the small bowel is severely adhered to itself through multiple laparotomies in the past. Or a patient, say for example, has got a very large abdominal hernia, where the small bowel is essentially sits outside the abdomen, along with transverse colon, in a big sort of abdominal hernia. So those are the kind of situations that you might think twice about doing this procedure. So the first stage that you would want to do in this one is essentially you would want to, there are variations in this, but these are the steps. So the first stage that you want to do is to create a jejunal anastomosis then what you would want to do is you would want to create a gastric pouch and then do a gastrojejunectomy. Now what I'm going to do is I'm going to draw this first, so when I'm describing it, you've got a mental picture of what I'm talking about. I'm just going to get a white print. Right, gastric bypass. Now, let's just say you've got the stomach, esophagus, stomach, duodenum, DJ flexure, and then the jejunum. And this carries on, doesn't it? For anything from 2 to 10 meters, believe it or not. Varies. Okay? And this goes all the way to your cecum. So, in no particular order, right? This is what we we're going to achieve through a gastric bypass. We would have done a stapling of the stomach to make a little pouch of the stomach with the remnant or the remaining bit still attached, obviously. So this is now, so food is going to come down here and it's going to get into dead end because it's disconnected from the stomach. That can't be, can it? So something else needs to be happening here. So the next thing we will do is, see this small bowel here? The small bowel here, somewhere along the line here, and I'm going to come back to about the lengths and stuff, somewhere here we're going to transect the small bowel. Okay, transect. I'm going to put a circle for upstream and a cross downstream. And this, remember, I'm going to go all the way down to the cecum. Right? And you see this one whereby you see the one with the cross on it, the downstream one which has been disconnected, this one is going to be brought up and get attached to the gastric pouch. Yeah? So now what you're going to have is, see this one is going to be stretched up and gets attached there like this. Alright? And this now going to go to where? All the way to cecum. Your appendix sitting here and all that. Okay? Now the next thing is, remember we still got now the one upstream, the one with the circle, is going to get attached to the side of this one. You with me? Yeah. So now what you've got is a jejunal anastomosis, and you've got a gastrojejunal anastomosis. So now, see previously food would have gone esophagus, stomach, duodenum, small bowel. Now it comes down into the pouch, goes through the new anastomosis, and is bypassing the distal stomach and duodenum. And that appears to be the critical thing about bypass. That's why it's called a bypass. And because of that, things happen in the body and your diabetes improves. Okay? So food is bypassed and it comes straight into your jejunum. And if you want to put some length along these, typically from the gastrojejunectomy to jejunal anastomosis, you have about 100 to 150 centimeters. I don't want to go into the details of why one or the other, okay? And the other one is the distance between your DJ and this one here. It could be as little as 20, 30 centimeters or 75 centimeters, depending on why you're doing it and who does it and their preferences. In general terms, the longer it is, the more the weight loss, but also the more complications, if I want to really simplify it for you. So typically, if you go for 100 centimeter, you get a decent weight loss, but if you go beyond 150, you might run into problems with malabsorption and difficulties with nutritional deficiencies. And same as here, again. So keeping it shorter is a balancing act. It depends also to some extent of where you're starting with the weight, whether you're super obese patients or a patient who's got a slightly lighter weight. So that's the orientation of the gastrojejunectomy. Now, remember, you've also got your transverse colon running here. okay? Right over all this. The small bowel is on there. So the question now is, how are you going to bring this small bowel from down here? Do you go over the colon, or do you go through the transverse mesocolon? Can you picture that?
Mm-hmm.
And they're both acceptable, okay? I usually go through the transverse mesocolon, and I would have created my window from above. So what I tend to do is, this is for the surgical trainees, so I'm just going to now wipe these off there, this bit here, and I'll show you the anatomy of. So if you think about the posterior, the retroperitoneum, you have the pancreas, which is sitting here like that, okay, and the retroperitoneum, which is kind of doing this, and then the transverse mesocolon does that, and which is attached to the colon. Small bowel is down here, and stomach is there. So stomach, pancreas, transverse colon, transverse mesocolon, and that's small bowel. So you can see, you can bring the small bowel either over the transverse colon to get to the stomach, or you can go through the transverse mesocolon. And let's not forget that attached to the transverse colon, you have got the omentum. And in obese or super obese patients, the omentum is quite thick. So one of the things that a lot of surgeons do is, if they're going to go over the transverse colon to bring this loop of small bowel over to attach it to the pouch, so I'm talking about this one here, this limb, they split the transverse colon into half, like splitting it like this, so that you don't have the bumpiness of that thick layer of fat to make the distance a bit shorter. Because what you don't want is tension here. You don't want so much tension. You don't want to go over a big hill, so you want to minimize that hill, that distance between down here and your anastomosis, so there's less tension. And one of the things that people do is split the transverse mesocolon to go over the colon. That's called anti-colic technique. The alternative to that is to go through this transverse mesocolon. Now critically, this is the critical thing, okay, is that the lower you are towards the pancreas, the thinner the transverse mesocolon. Obviously you don't want to go through the pancreas. And you can actually see that layer, the gap between the pancreas and the transverse mesocolon much better when you're looking at it from above. Now again, anatomically, let's remember anatomically, what is it that is connecting? Remember that? See this? That's the omentum, isn't it? Omentum starts from the colon, because that's the stomach, isn't it? Yeah. So to get to here, you need to divide this attachment here between the transverse colon and stomach, the omentum. And once you're into this, and what is this space called? Lesser sac. So once you're into the lesser sac, you push the transverse colon down with the transverse mesocolon down, and then you can very clearly identify the gap between the fatty transverse colon and that kind of deeper yellow color of the pancreas. And you pick that up lowish down, not high up when it's thick, and a couple of application of the energy device and cut, and you're into the infracolic compartment, where then you will push this limb through to bring it up to get attached to the pouch. Can you visualize it? Is the anatomy clear? So those are the different approaches for this. I'll come back to this, but it's probably worthwhile now remembering all these holes and spaces we're creating. Yeah, things can then twist and protrude and herniate. And that's where a lot of complications can happen. I'll come back to that. So, jejunal anastomosis down here, and gastrojejunalostomy up there. You can do them hand-sewn, you can do them stapled. I usually do this one hand-sewn, a very nice video on, if you want to watch it. Higa does a beautiful gastro-jejunal anastomosis hand-sewn. I would advise everybody who are interested to go and watch that. Higa, American surgeon, he does it beautifully. So I do my anastomosis here in 2 layers, hand-sewn, and down here I would create my enterotomies, staple inside, apply the stapler, and then closure of the enterotomies with a running suture with a phlebotomy. So that's the gastric bypass. Just a brief note about sleeve gastrectomy now. So a sleeve gastrectomy, going back to what I mentioned earlier, is an example of a restrictive procedure in that you're basically not bypassing food, but you're making the stomach smaller so that the patient can't overeat. So in simple terms, what you're doing in sleeve gastrectomy is, if you think about the stomach, you're basically stapling the stomach along its long axis, leaving a tubular stomach, like a sausage of a stomach, with the excess stomach all removed out of the body and sent to pathology. So what you end up is a long column, and the inner diameter of that particular stomach in the procedure that I do is my finger, the inner diameter. So you can see how thin it is. And that is a high pressure zone, and you can just imagine a column of food. The patient is unable to basically overeat because you don't have that sac where you can just expand over time. So you've got a restrictive procedure, and that's called a sleeve gastrectomy. The main limitation of any restrictive procedure is that it only works if you are taking mostly solid food, essentially. So it works best with lean protein, solid lean protein. So the analogy is that it doesn't matter how small the restriction is. If you've got a bucket with a hole in it, and if you pour water, the water eventually leaks. Whereas if you've got bricks in it, it won't. So for any restricted procedure, there is more reliance on patient's compliance for it to work, as opposed to when there is a malabsorptive element. And this is why there's perhaps typically a smaller percentage weight loss is achieved. There are exceptions. There are patients who achieve really good weight loss, but I'm talking about average. It tends to be less. Even on occasions, patients fail to even achieve that 50%, and certainly I've seen them. So in theory, somebody with a sleeve gastrectomy, it doesn't matter how tight it is, if you were to eat liquid calories and food which is slippery and melts in your mouth, then you don't really going to achieve much weight loss. So that's the biggest problem. However, it is quicker to do surgically, and also the patients also tend to kind of visualize it easier, as opposed to this configuration, which is a little bit more tricky to kind of describe and visualize. For a sleeve gastrectomy, the size of the tube that you leave matters, because if you go and make this tube that you're leaving, the gastric tube, too large, well, essentially you will not achieve much weight loss, and the restriction is limited. However, if you make it too tight, you can run into other problems. So it can stricture, it can become ischemic, it can kink, and if you ever have a leak from a tight, very narrow gastric tube, it's very difficult for it to heal because it's a high pressure tube. I don't know how many of you have ever tried to inflate a balloon, like any balloon for that matter. To begin with, it's very difficult to inflate it, isn't it? Okay, so that's because it's such a high pressure that you require to counteract the tension in the wall of the balloon. But as soon as it becomes bigger, then it becomes easier to inflate it even more. So initiation of inflation balloon is very difficult. And this is why the smaller the gastric tube, the higher the tension in it and the more restriction, but the bigger the problem. So a 40 French, do you know what I mean by French? Yeah, you must have come across that maybe in these gastric tubes. A quick way of kind of converting French into metric kind of is dividing French by pi. Mathematical pi, 3.114 or something. Yeah. So if you just divide it by that, then it essentially gives you the diameter, as a rough guide. So 40 French, it's 42 French is, so by the time you're using like 55, 56, 58 French, this becomes quite large, and the restriction of the gastric tube that is remaining is diminishing. And of course, there are other considerations when it comes to how tight you're making it. It's not so much the size of the bougie, but also you're going to be resecting the stomach using a stapler, aren't you? And how tight you're going against the bougie also matters. So you can have a size 40 French, but don't go tight against it, or you can have a size 50 and go really tight against it. My advice always is don't go tight against any bougie because it can cause problems. If the bougie is really, really malleable, you can accidentally just go staple it, but you can also create a lot of tension at the point of stapling, and the staplers can fail because the stomach is being stretched against the anterior and the posterior border of the bougie against your stapler, and the staplers can not misfire, but they can fire, but they can just tear. So that's an important consideration. And the other important consideration is that anatomically, there are a few things about the stomach that you always remember. Number one is that the stomach posteriorly is pendular. So if you look at the stomach, it's got the upper end of it, which is attached to the lesser omentum, isn't that right? Mm-hmm. And the greater curve, the lower bit, is attached to the greater omentum. So if you were to grab those two ends and stretch it, or you just look at it from the top, from anteriorly, it looks quite nice and stretched, doesn't it? But if you were to somehow get to the back of the stomach, and if you became a miniature person and went to the back of the stomach, and you see that the stomach is actually quite pendular at the back. So it's very important when you are stapling against the bougie to bear that in mind, in that you're not leaving quite a sac or a remnant stomach in the back, excess. So things in the front might look all nice and cozy and tight, but then you leave quite a bit of stomach at the back, which then essentially affects the patient's restriction, and it affects the percentage excess weight loss that the patient will achieve. So you want to get that excess stomach from the back of the stomach excluded from the bougie side before you staple. Another anatomical consideration, you can see how the anatomy is so important when it comes to surgery. So the stomach is not the same thickness. The thickest part is distal, the thinnest part is posterior fundus. So it's important to consider when you're applying your stapler. So people use different color staplers. So there are, depending on which company or which manufacturer your preferences are, or your stapler is available, they come in different sizes. So if you've got a very thick layer, what you should do is use bigger staplers. The analogy is that if you've got a very thick layer of paper, and if you use an ordinary stapler, what will happen? The bottom pages will just fall apart because they're not reaching right down to the whole layer. And vice versa. If you've got say two or three sheets of paper and you want to staple it with a big stapler, those two looses, you know, they're not stapled nicely together. So it needs to be an appropriate size, and that's important. Do you use reinforcement? So there are different ways that you can reinforce your stapling. So when you're stapling along here, you could, for example, afterwards underrun it, or you can bury it with running sutures. You could patch it with omentum. You could use materials such as SimGuard, which is kind of an absorbable, biodegradable material that reinforces it. All of these have been used. In my experience, you know, if you've really used your stapler and stuck to the important technical considerations and you've done a nice operation, the less you do to this, the better. If you were to use any kind of reinforcement, probably, since you're doing a stapler, you might as well use a reinforcement which is incorporated into your stapler, something like a SimGuard. So which essentially is like two sheets of material that is worn on both jaws of your stapler, and when you fire it, essentially it's reinforcing it, creating another layer. And in my experience, it kind of perhaps reduces the bleeding. But does it reduce leak? Not sure about that. Certainly the data doesn't suggest that. Once you've removed the stomach, detached it from the tube, the extraction of it is another matter. I should have also added that obviously this stomach is attached to the greater curve all the way around with the omentum, and you would have divided it off the omentum. It goes without saying. So you would take your energy device and you essentially, this is for the sleeve gastrectomy, you fully mobilize the greater curve, and then from the pylorus, usually leave about 6 centimeters or so, whereby you don't touch the omentum for blood supply and nerve supply, and that's where you start your stapler. You don't go any more distal than 6 centimeters away from the pylorus. And then once you've divided your greater curve adhesions, then you lift the stomach and you divide the posterior adhesions fully to be able to resect the posterior wall of the stomach along with anterior as well. And then you extract it typically through one of the lower ports of the 12 ports. And with a bit of a patience, you don't tend to even need to extend your incision. You just kind of tease it out. The kind of things that also could go wrong here, just have to bear in mind if you've got a nasogastric tube, don't staple it. So those are the kind of steps of the sleeve gastrectomy. Now, some general kind of considerations when it comes to complications. Now, firstly, we tend to kind of associate leak with peritonism, peritonitis, abdominal tenderness. Those are the kind of things that people naturally kind of imagine. But signs and symptoms in a obese post-operative patient is not typical. Now, just a slight sidetrack, although this talk is mostly about weight loss surgery, remember a lot of our patients who have other types of procedures are also obviously are overweight. So complications that can happen out with this particular specialty can also present in these atypical fashions. So patients typically, if you go and feel an abdomen, a super obese abdomen, they're not going to show you any typical guarding or rebound or percussion tenderness, bowel sounds. Those are the kind of things that really, so you kind of rely on experience and the ability or eyeballing the patient is important on, say for example, if if a patient the day after surgery is still in bed and just doesn't look right, probably something is wrong, till proven otherwise. And that is why it's so important to mobilize patients out of bed so quickly. A patient who's mobilizing and looks well and looks happy is much less likely to have mischief going on inside the belly than somebody who's in bed, generally speaking. Of all the indices and measurements, I would say tachycardia and hypoxia are the two that I would probably pay most attention to. So if a patient you don't think it's pain and there's no other issues, and the patient is running a tachy of say 120, 130, and also or is hypoxic, there is something wrong till proven otherwise. That's important. And don't exclude this just because there are no typical signs of peritonitis, or just because the bloods are normal. The other very important thing for any surgical patient is early detection and treatment, and in particular in patient subgroup where they've got compromised physiology. So they've got a very, very narrow window where they will hold on, and then they will just become very unwell very quickly. If a patient is unwell on the afternoon, evening ward round, do not leave it for 10 o'clock doctor to come and re-evaluate. You need to sort that patient out there and then. You certainly don't say, let's get a CT scan and then find out the CT's been done or still hasn't been booked by the following morning. It will be too late. So a patient who doesn't look right needs to be sorted out there and then. So for example, in our unit, we've got a policy, if a patient is not right, then the registrar, the trainee, assesses the patient and then picks up the phone and speaks to one of us. And then we will then speak to a colleague, a consultant colleague, and then to consult decision, and this patient typically goes back to theatre rather than wasting time. CT scan, if you're going to do a CT scan early on, remember this patient probably will have gas from pneumoperitoneum, okay? So that's not very helpful. And you would have had maybe wash and fluid. So unless you give them contrast study and it leaks, then that probably be diagnostic of a leak from a gastrojejunal anastomosis. But what about this one, if there's leaking from here? What if there's a leak from the remnant side of your gastric? Then none of them are going to show on a contrast study. And you will see fluid and gas. So a CT in a patient that is suspected to have got a complication is useful in a sense of planning for surgery rather than excluding that I'm not going to do an operation or I'm going to do an operation. That's the way. There are always exceptions to this, but that's the mindset. So mindset is rapid assessment and rapid treatment, and the treatment is in theatre. And if you're deciding for a CT scan, is not so that you can then say, oh, that's fine, and the CT just should show a little bit of gas and a bit of fluid is probably a wash. And the patient by this stage is improved because they've given him some fluid. This patient is probably better off to go and have a relook laparoscopy. A relook laparoscopy, which is negative, is far better. So a negative laparoscopy is preferred over a missed opportunity. The group of complications are leaks, bleeds, internal hernias, and anastomosis strictures, and there are other ones. I mean, the big one is DVT, which is kind of like not like immediately surgical, but is very relevant, and in fact is probably the biggest problem after this particular type of procedure, because heavy patient, poor mobility, high risk pneumoperitoneum, and these patients are at a high risk of developing DVT and pulmonary embolism. So you need to make sure that these patients are mobilizing preoperatively. So in some centers, including ours, patients actually walk to the table from the ward. And then right after surgery, ideally on the day of surgery in the evening, they need to be out of bed. They would be getting DVT prophylaxis injections, a fragment in our case. They will be wearing TET stockings, and intraoperatively they will also have intermittent calf compression. Post-operatively, they should avoid dehydration, and particularly even when they go home. In our case, they go home with 2 weeks supply of fragment that they self-inject. And also they need to remain mobile. They don't go home and sit or lie in bed. Despite all that, you still get a percentage of people that come and with DVT and pulmonary embolism. The PE tends to be the biggest killer, in fact. We talked about leaks. Now, out of the leaks of the gastric bypass, it's more common to have a leak at the gastrojedge, but if you have a leak from a jedge, it's more of a problem. Okay? So a jedge leak tends to present later, and the leak dissipates quicker, and the patient becomes sicker, and they do worse. But it's less frequently seen than the gastrojudge leak. The sleeve gastrectomy leak is the worst. It's rare, but it's the worst one to treat because it's a high pressure zone. And so depending on the findings and the timing of the leak, your treatment will be different, isn't it, in the case of leak? Let's just say, for example, that you find a leak immediately intraoperatively, but then you need to rectify it there and then through further reinforcement. So the kind of things that, for example, some surgeons do, including myself, is that once you've done your gastrojejunectomy, you will be passing a nasogastric tube through the anastomosis, sitting at about here into your alimentary limb of your Roux-en-Y, and then you block it lower down with a bowel clamp, and then you insufflate or you put air into it. But then you would have filled the upper abdomen with fluid, and you just look for any air bubbles. Air leak test. You could also, instead of that, or in addition to that, put a dye in a liquid form and look for discoloration. Methylene blue, for example, is a good one. So you get, say, 1 or 2 mL of methylene blue, you dilute it in 60 mL, 50 mL of saline, and then you basically inject it through your nasogastric tube. Your anesthetic colleague will do that for you. And then while you're doing that, you check for any leak. But if you see a leak, you need to rectify it. However, let's just say the leak has happened on day 6, day 7, and you've taken the patient to theatre, and this patient has got contamination and an abscess. But then you're really not into any closure surgically. Your options are drainage, wash and drainage, and then think about, so that's a control of sepsis, control of any ongoing sepsis, but also nutrition. So you need to think about how you're going to feed this person. So particularly in problematic kind of leaks, if you think that this patient's oral route is going to be a big problem, you might even consider, for example, a feeding jejunostomy. The central line is a tricky one, isn't it? You know, they get dislodged, they get infected, they've got a short lifespan, whereas you want a more secure feeding route for this patient. And a feeding jejunostomy is one way of doing it. So if you're going to drain this, for example, you might consider putting a nasal gastric tube and further drains in and around this area, coming out of the abdomen, 2 or 3 of them, feeding jejunostomy, and then depending on how the patient is, goes into a intensive care, high dependency or intensive care unit for further care. And typically that one heals, no problem. This one, if it's leaking, and if it's in a really bad shape, it becomes a little bit more problematic because it tends not to be easily drainable. Because it's just sitting in a big compartment in the abdomen, and if it's leaking, it's difficult. So you need to do something about that. So one of the easiest thing to do, in my experience, is just to revise it in a patient that can withstand. So operating in a case of, so these are all the other finer aspects of this. If you're operating on a complication, it's always a good policy to have one of your colleagues in with you. Some people argue that the best results are if somebody else operates on your complications, but that's not what a lot of people do, isn't it? You know, because when you're emotionally involved with the case, your judgment can be affected. Whereas if somebody is coming from outside, they can be much more objective about their decision making, and some of the biases are taken out of the equation. As you know, the scientific definition of bias is a subconscious factors without you knowing is affecting your decision making. You don't even know it, but it's affecting your decision making. The leaks here are more of a problem. Most of the leaks, whenever happens along this tube, tends to be high up here. And typically, for example, if the stapler has accidentally taken a little bit of esophagus, and that's not good. So you always want to staple the stomach side. So you leave a tiny bit of dog ear here of the stomach. You don't go on the esophagus. There are many reasons why leaks happens there. Many talk about maybe poor blood supply high up there, but in my experience, that is a factor. But if you sort of stick to the basic kind of principles of staple usage, then you avoid many complications, and there are many aspects of the stapling when you're using a stapler. So for the sake of trainees, so what are the sort of indications? There are many aspects of using a stapler. We've already talked about the size of the stapler, so I'm not going to go through that again. And that comes in different colors. So in theatre you hear, oh, give me a green, give me a blue, give me a white. What they really mean is different sizes of stapler. Okay, green is bigger than blue, and blue is bigger than white. There's also gold, for example, or black, which I've never used. So these are size of the stapler in relation to the thickness of the stomach. If the stomach is already